got an opening question. I can't see whether Celeste is in the room or not, or able to do this, Tamsin, because I can't currently. All I can see is the presentation now, so I can't currently see if she's in there or not.
I am here, but I just have to start the recording. But I am just going to have to pop in and start the recordings in the other workshop, so I won't be back for a couple of minutes. Sorry.
Okay, thank you. So are you starting the recording now? Okay,
I think I think we're good.
Okay, so everyone, just a reminder that this session is now being recorded. So if there's anything, if you want to share anything later on when we do questions, then if you don't want it to be included in the recording, just say when you speak, and then Celeste will delete that out. So just a reminder. So shall I hand over to you to explain this, Tamsin, and then I guess we'll just do it in the chat?
Yeah, absolutely. Yeah. So we'll kind of collect answers, but I think one of the questions that we were interested to know is whether there are how many MMHSs, whether you are part of one or whether you are linked or know about your local one, whether you're already offering a service to the separation at birth cohort. That's what SABS stands for, sorry. And if not, are you planning one? So we'd be really interested to know whether that is on the way, in progress already, and whereabouts you are. So if you can pop that in the chat, we would be very grateful. And I think what we'll do is we'll carry on, but please do, do that as we're going along. But we're going to move on because we obviously lost a couple of minutes at the start with our tech issues, so we don't want to lose too much time.
Okay, brilliant. I will kick off with the first few slides then. Thanks, Tamsin. So as I said at the beginning, I'm from an organisation called Birth Companions. Some of you may have heard of us. We're an organisation that was founded 27 years ago to support pregnant women and mothers at HMP Holloway. So we started out life working with women in Holloway Prison, but we expanded to work in other women's prisons across England, and also with women in the community. So we are based in London, but we work across England in different places in the prisons. So we consider ourselves the UK's leading voice on disadvantage and inequality in pregnancy and early motherhood in prisons and in the community. The women that we support are facing incredible disadvantage, multiple disadvantage and inequalities when they are pregnant and experiencing early motherhood. So we provide a number of different services, which I'll talk a little bit about later. But we provide practical and emotional support and advocacy to the women. And we have we have a staff team, but we also have a large number of volunteers that support women at birth and in early parenting. We have a policy and influencing work, and that work seeks to improve the care and reduce inequalities at both the local and national level. And my role at Birth Companions, as I said, is head of engagement, and we have a team of incredible women, over 50 women, who have all, or predominantly they've been supported by us, but they all have lived experience of inequality and disadvantage in the perinatal period. And they have chosen to stay with us, to join our team, and to promote best practice, to share their experiences, to take part in collaborative work with co-production opportunities. Again, I'll talk a bit about that later. And those opportunities span different systems. So predominantly it's all in maternity because we're supporting women in that period, but also because of our link with prisons, we work within criminal justice, and also because of the situation that women are often facing, we also work within children's social care systems. So the members of our lived experience team, they take part in all different kinds of opportunities, but they are always paid for their time, and we think that that's really important. So when we talk a little bit later about how you might involve women with lived experience in co-producing services, I just thought it was important to note that within our work, they are paid for their time. So I am going to talk a little bit later about one specific piece of work that we're doing that relates to Hackney. But for now, I'm going to talk a little bit more about our frontline services. So our frontline services within London, so we have birth support, we have antenatal classes and a mother and baby group. And these are, as I said, these are in London, and we work very closely with Hackney, and we have been doing a considerable amount of work for a specific cohort of women within Hackney. So we have been co-designing a new service which will be based at Birth Companion. So it's a new service that we will be offering, and it's specifically going to be for perinatal women in Hackney at risk of and experiencing separation, with local working with local stakeholders and women with lived experience. We have been able to design a new service, and again I'll talk a little bit more about that later, but that relates to talking about our work today and specifically the work in Hackney. So another thing sorry, so another area that we've been working with specifically within Hackney is with Ocean, and it says on the slide kind of where they're working and what it is that they're offering. So Ocean, we've been working with Ocean to co-design with women with lived experience a maternal mental health service for women when they are separated from a baby. So just thinking about our kind of services within Birth Companions, but also the way that we can work with the statutory services to help support these particular women. And just to finish off before I pass over to Tamsin, I just wanted to tell you a little bit about the women that we support. So at Birth Companion, 61% of the women that we support have contact with children's social care. And last year we supported 65 women through the removal of their baby or who have been separated recently from their baby. So the experience that we have supporting these women, and then those women who then join our lived experience team, we're then able to be involved and to support the work that is going on, particularly within Hackney. And for the last 3 years, we've been working with the Centre for Family and Justice Research. And this is of particular note here because we've been involved with the development of the national guidelines, and they are to support practitioners who are working with women when they are separated from a baby. So again, I'll talk a little bit about those later, but those national guidelines, the latest version were actually published 2 days ago, and they've been developed by the Centre and Lancaster University to support health professionals. So if you are interested in this and you haven't heard about it, then we will provide a link. And we've also had key involvement in the development of the Hope Boxes. And those hope boxes, Tamsin and I will both talk a bit more about later, and they are currently being trialled at the Homerton, and they are boxes to support women when they are separated from a baby. So I'm going to pass over now to Tamsin to do the next few slides. Thanks, Tamsin.
Thank you. So lots of you, this won't be news to, but I think just in case there are some people who are a bit less familiar with this cohort, we thought we'd just highlight some of these things from the national picture. So successive embrace reports, all of them have showed that there's inequalities in outcomes for this cohort, and actually 1 in 5 of the women in the most recent report who had died had involvement from social services, which is a marker of high levels of vulnerability and trauma. More than 1 in 10 of those who died by suicide and 59% of those who died through substance misuse had an infant removed from their care, or they had ongoing care proceedings. We know that the number of babies being removed at birth is just continuing to rise, and it's more than doubled since 2008. And also in terms of the outcomes for babies, we've had 3 studies now, not 2, that have shown higher rates of preterm birth in babies born to this cohort. So actually there's a lot of work to be done to kind of ameliorate the effects. Kate, can you move forward to the next slide? Yeah, so I just thought I'd give you a bit of an idea about the service that I'm coming from as well, because I think it'll become clear later that it does affect what kind of service that you are able to offer, because it depends on the numbers of women that you've got coming through. So at Homerton, we have about 5,500 births per year. And from that number, it's the average of about 9 removals at birth per year, which is a small number compared to some places. And I think that is an important thing to bear in mind when you're thinking about what you might have to offer, because actually you need to know what your population is. I think in my experience, and I've worked at Homerton since I trained, and previously was the specialist midwife for substance and alcohol misuse in the area as well. What we've seen in our area is actually an increased number of women going home to mother and baby placements, foster placements, rather than a removal at birth, particularly first-time mothers and young mothers. So that's a change in practice that is really positive and is not something that I think is echoed everywhere in the country. We have quite a lot of midwifery resource going into caring for women with vulnerabilities and complex social lives. So we have midwives who are band 7 midwives who specialise, one in substance misuse, one in mental health, one for our Ocean team, one who does sort of general safeguarding things, and then all of our community team leaders have a dual responsibility. So they lead the teams and they also caseload vulnerable women. So there's quite a lot of midwifery resource, and I think that's another thing to bear in mind when you're thinking about what your service is going to look like, because there does have to be a good link with your midwifery teams as well. And I think one of the things that we try really hard to do, and it's an ever increasing need, is to try and look after the staff who are looking after these women. So women who are experiencing or at risk of removal at birth have obviously got a lot going on, and caring for these women is emotionally hard. So we have supervision, but we also clinical supervision, safeguarding supervision, but we also have an external psychotherapist who runs regular supervision sessions to kind of provide that restorative support, in addition to our PMA team as well. So there's quite a lot that we do around that. Can we move on, Kate? And this slide, I just wanted to talk a bit about intersectionality. So the fact that 5 times more we're going to be doing their workshop, and the other workshops that are going on today, all of these issues are so interlinked. And this particular group of women, particularly, I've done a bit of a pun there, these marginalised women are labouring under many layers of inequality and injustice and prejudice. So, where actually a woman is coming into a maternity healthcare unit, the culture of that unit, and if it's a very patriarchal, traditional, obstetric-led medical model, where those power dynamics are in place, actually this power and that kind of imbalance might be exercised by all professionals, regardless of gender. So that's a kind of thing that we need to bear in mind. Race. So in my research, I looked at 3 years worth of cases, and actually the numbers of women from non-white backgrounds experiencing removal at birth was disproportionate to the general population of maternity patients coming through our service. And this kind of does echo that wider work on social care and criminal justice involvement across the UK. We know that women commonly living in poverty, and then that will impact on their general health, how they access healthcare, whether they can access healthcare. And it will come as no surprise to everybody here that actually the great majority of women, and I think probably this is just all women in this situation, have their own histories of trauma, whether in childhood, adulthood, or both. So they've developed these maladaptive coping mechanisms that lead to, having babies removed when they are born, and lots of these women are care experienced themselves. And they also up against the social stigma So these are women who have subverted the traditional expectations of women, of motherhood, and I think that's very challenging for lots of people as professionals. And I think what happens a little bit is that this group of women are put in the too hard box, and that's why we see that actually, you know, the MMHSs are the first service that, you know, I'm aware of that's been specifically mandated to try and meet the needs of this population. Okay, can we go to the next one? Is it moving for anyone else?
Can you see that?
It hasn't moved for me, that's fine, don't worry.
Building block 1?
Oh, okay, fine. So what we've done, I think we've got 4 building blocks that we thought might be we've suggested as things that might be helpful if you're planning a service. And actually, this is about identifying who your separation at birth cohort is. So how many do you have coming through or, you know, experiencing this in the maternity services that your MMHS is serving, bearing in mind that actually the one that is linked to my hospital and my borough is covering 3 boroughs. And who cares for them in the maternity service? How are they cared for? So are there specialist midwives who can give them continuity, who can give them extra time, who can do assertive outreach, or are there not? And how many people are those midwives caring for? What's that capacity looking like in your maternity services? Then who in the maternity unit and your local maternity system is going to advocate for this group? So at my hospital, it's me, but not every hospital has someone in a similar role to me. I think there's only one other midwife that I know of in a consultant midwife role with public health and safeguarding. So your named midwives, or is there somebody else in a senior position who really gets this cohort and gets the work that is needed, and will drive forward and bring this up on the agenda? Thinking again about your ethnicity and your comparison against the general population. I think this is something that everyone's getting better at having a really good awareness of, but I don't think this group, which is obviously a very small cohort, it's a fairly niche group, but actually it's a really, really important group for us to think about in terms of our equity and equality plans. What about your women? How many of them have pre-existing serious mental illness? How many of them meet the perinatal mental health criteria during pregnancy? So what level of need are you facing? So I think we are thinking about 2 different groups. There's those who have pre-existing SMI diagnosis and those who don't, but have experienced loads of trauma and may have CPTSD, but hasn't been diagnosed. And there's 2 separate kind of things that need to happen. And think about the other things like, you know, have they experienced a previous birth trauma? What else is going to be impacting on their experience? I saw in the chat somebody was talking about working with women in pregnancy when they've had a history of removal. So no matter whether this one looks like it's going that way or not, I think that's a really important piece of work that we'll talk about later as well. So what I would like to do is a poll, and if Celeste is here, then we can do a poll, but and speak up if you are.
I am here.
Hi. Would you mind putting this one as a sort of yes, no poll? Do you have information on your cohort in your local area?
Yes, I will try.
Thank you so much.
Is that coming up for people?
Oh, I can see something's happening. Yes. Fabulous. So it's in the chat, but it's probably also going to pop up on the main screen as well. I think I probably will add a caveat as well, that I know that there are very, very different levels of digital maturity in the different maternity services across the country. And depending on how well developed yours is, it might be harder or easier to get this information from your midwifery team. But your safeguarding midwives, your safeguarding teams should be able to get this information for you, at least on numbers and things like that. Okay, right, please do carry on doing that. And I think I am handing back over to Kate.
Oh, we've got one more, which is,
one
I don't
more.
know if you can see it, Tamsin. It's women's experiences more than
yes.
the baby was lost.
Yes, okay, fine. So this is pulling out some of the information from the research that I did a couple of years ago in terms of loss, and you know, especially when we're thinking about this service that we're talking about today, there's so much in addition to the loss of custody that these women experience. And a lot of the time where there's complex social issues, safeguarding planning takes precedence over choice, over personalisation of care, over the normal experiences that people might have. So loss of the normal motherhood experiences, that's a big one, and that kind of encompasses lots of different things. And that might include loss of birth planning, infant feeding choice and support, debriefing services. It can be a loss of privacy and dignity. And I, in my research, spoke to a woman who was considered so high risk that 6 or 7 policemen were on the birthing unit as she was giving birth and came into the room while she was still being sutured. And actually, I think, you know, as soon as I say that, you can realise how inappropriate and how unnecessary that is, and how awful as an experience that is. Loss of time to connect with baby and time to say goodbye. And I think this, again, is something that varies from place to place. Some places will have a policy of putting the, you know, admitting the baby to a neonatal unit and sending mum home as soon as humanly possible. And that might be about bed spaces, or I don't know, whatever it is. But, you know, where I work, we will keep mum and baby together for as long as possible, and certainly as long as she is feeling able to care for her baby, until the kind of the court case is resolved. Loss of postnatal care, so from anyone, from a lot of the time these women find it really hard to engage with any kind of care in that immediate postnatal period, which is understandable, but it's on us to try and do that better and work out what they might need. And then loss of future children, family life. Some people might choose never to have a baby again because they think the same thing will happen, or because it has happened repeatedly, or they might, you know, go into this recurrent series of having babies that are, you know, taken away one after the other. And then loss of this motherhood identity, and this is something that comes up again and again, because the way that our systems are set up, and the way that our systems are working are taking away and denying women that motherhood identity. So as soon as you are no longer eligible for perinatal mental health services if your baby isn't with you, as soon as your health visitor doesn't come and see you because your baby isn't with you, we're saying, well, you're not a mum anymore, you're not a parent, because your baby isn't with you, so we're not going to come and do anything for you. So that, I think, is a really, really big one. I think the next slide we're just going to skip over, really.
Yep.
So people, you'll be able to look at this in more detail later. This is just some more of the findings from my research. We thought we'd leave it in there, but I'm not going to talk it through, so we can move on.
Okay, so I think we're back to me now. Thanks, Tamsin. I'm going to talk a bit about the Giving Hope project, and then I'm going to pass over to Tamsin, who's going to talk about the Hope boxes at the Homerton Hospital. So as I said earlier, Birth Companions have been working with Lancaster University and the Centre for Child and Family Justice Research, and we've been doing that for about 3 years. So this is a project that we're really passionate about, and I'm so pleased to be able to talk about it today. Now, the main project was about the national guidelines, which is they aim to support professionals. So to give you guidance and support when you are navigating the very challenging situation when a woman is being separated from her baby at birth. But I want to talk specifically about the Hope boxes. So the Hope Boxes are part of this project, but they're an intervention to help support women when they're separated from their baby due to safeguarding concerns. And they were co-produced by a group of women with lived experience. They are an incredible group of women. And what happened was it really took on a life of its own. We started talking about memory boxes and about loss. And we had heard that in a couple of areas in the country that midwives were kind of using some of those memory boxes and trying to work out what might be positive for women to have when they're separated from their baby. Anyway, this group of women, I think there were 15, between 13 and 15 in the beginning. They'd all experienced losing a baby at birth. And so they designed from start to finish, from the emblem on the boxes to everything that's inside. All of it was designed with women with lived experience. One of the women at the back of the room when we were first talking about it drew the emblem that you can see on the screen now, the hands and the feet. And the idea is that there's two boxes. So one stays with mum and one goes with baby. These boxes are introduced by the midwife caring for the woman when she's separated from her baby. And the key thing to understand about the Hope Boxes is that they're a connection box in the first instance, because until the end of proceedings, that separation is an interim separation. So the boxes were designed to help keep the connection and the engagement to give the best possible chance of reunification. And then after, if the situation happens that a final order is in place and they are separated, then at that point we think of them, as memory boxes. So inside these boxes, the things that are inside there to help reduce the trauma are the kind of memory making activities. So there's an SD card to take photos. There's a letter from what they call themselves the Hope Mums. So there's a letter from these women with lived experience, and there's a poem that they have written inside the box. All these things are about connecting those women so she knows she is not alone and that women have experienced this before. And the things that are in the box are about keeping connections while decisions are being made. There's a storybook, there's a baby book, there's a blanket that can be exchanged at visitations with the smell of mum and baby. There's a candle that a woman can light. There's a soft toy, there's a notebook, there's a support list. Every single one of these items, the colour, the design, the writing, everything was designed by women with lived experience, and they are produced in a factory in the northwest, and they are currently being piloted in hospital trusts across England. And we were lucky enough to make sure that that Hackney and the Homerton hospital, the only London hospital that are taking part in the pilot, and they were delivered there last month. And I'm going to pass over to Tamsin to talk about the Hope Boxes in Hackney.
Thanks, Kate. Yeah, so this is something that we're so excited to have, and we are trying. It's part of a wider QI project looking at the whole maternity pathway for those who have experienced a previous removal or they're at risk of removal in this pregnancy. I think one of the things that it's really key for maternity services to get a handle on is that we actually need to try and prevent further traumatization or re-traumatization throughout the maternity pathway, as well as having services like the MMHSs to kind of help manage when those traumas have happened. And these boxes, I think, are a really helpful, tangible thing that staff can do with women, and I think it's the sort of things that it's going to help build skills and confidence in the midwifery workforce and the maternity workforce in talking about these quite taboo topics, talking about this thing that is really hard to do. And I think lots of midwives are doing people. You want to try and fix something, you want to try and do something for someone, and this is something that is one of those things. So it also reinforces that idea and the concept that this person is experiencing a loss. Even if it's potentially temporary, it is a loss, it's a grief, and it helps connect it in the minds of the staff to when people experience other types of loss, that actually that we are probably much better at discussing with them. Even though that's still hard, we probably are better than that. So we were really excited to have two of the Hope mums come along with Kate and some of the team involved to come and hand over and talk us through the boxes last month. And we are developing a pathway that includes other things around how women are cared for, planning for birth and planning for that postnatal period in two ways. So we can say to the woman, okay, if you and baby are going home together, that's what you want. Who's going to support you? What do you need? Who's getting home with you? All those sorts of things. If it doesn't go the way you want, and you're not with your baby, at least in the temporary, situation, who's going to go home with you? Who's going to look after you? What do you need from us? How can we best support you? So trying to do some more of that preparation with women ahead of time for those who are able, bearing in mind that this is going to be very individual and some people really, really can't face that or talk about it. Some people can. So yeah, there's lots of work going on there as well. I think that's all I need to say. We've
got building block 2 before it comes back to me, Tamsin.
Fine. Yeah. So this is about, and it's really, really nice to see some of the services that we're going to be, wanting the MMHS services to identify are actually in this meeting. We want you to think about what wider context does your service sit in? So what else is around? What does the system look like? So I'm endlessly banging the drum that I think perinatal mental health teams should keep on women that are known to them in pregnancy. And it's something that we can go back and ask. I haven't quite worked out who gets to decide yet. So I'm just asking the question wherever I go and wherever anyone will let me. What happens to women? Somebody was talking about in the chat, I saw community mental health teams that's where women will be referred onto. But the danger there is that we know the reason that perinatal mental health teams exist is because it's a special time that needs specialist knowledge and experience, and the community mental health teams don't have that. If you then connect that back with the current service provision is resulting in suicides at an awful scale in these women, and so clearly what we've been doing so far isn't supporting women in the way that it needs to, and our perinatal mental health services for people who have pre-existing SMI are best placed to continue to provide that support for them. And I think in an ideal world in the future there would be really good working together between the MMHSs and perinatal teams and any other team that people need to kind of make sure these women's needs are met in the safest and most effective way possible. I've also mentioned about health visiting as well. So I don't know, and I would love to know if there are places in the country where health visiting teams do see women who have had a baby removed, but currently where I work, they don't. But I'm hoping they soon will, providing that we win a contract that we're waiting to hear about locally. Because if you think about what health visitors are or do offer for everybody else, screening for mental health stuff, listening visits, general health, these women need that more than anyone else, in my opinion. So that's because that relationship can be started antenatally now, that's potentially a really good source of support. Then thinking about your local authorities, depending on where you are, you may work with predominantly one or you may work with loads. But what's their culture around pre-birth assessment? Do they have a specific team? Where are they with anti-racism work? What does that look like? What's the common practice? Are they asking people to sign Section 20s as a matter of course? Sorry, Kate, I think I'm catching your breath. And what does that look like? Who are there people who are really interested in developing some work with you around this cohort? And then I know that we've got Empower in the room. Hello, Empower. I've heard about you. Is there a recurrent care service in your area? And somebody has helpfully put one of the links that we were going to share, which is the research and practice map of recurrent care services in the UK. So go in, have a look. We have PAWS in Hackney and some of the surrounding areas. And what's their model or their eligibility criteria? So for me, where I work, PAWS don't work with pregnant women. And that's part of the reason that we need the service that Kate has been, and Birth Companions have been working with us to co-design, is that actually for us there's a bit of a gap around that pregnancy and immediate postnatal period. And that will help inform what you need in your local area as well. And then which charities are there? Birth Companions, for me, I think, it would be really sad. Well, it is really sad working in this kind of area anyway, but if we didn't have the kind of organisations like Birth Companions and various others that are able to do some of this work with us, we know how much general NHS, statutory services are struggling. We don't necessarily have the time and the space to give the kind of relational care that we want to, and that's where other services come in and kind of bridge that gap for us. And yeah, find out who your allies are and band together with them, and then go and bang your drum wherever they'll let you bang it. Okay. I wonder, should we try and, I'm seeing a couple of people can't see the slides. Should we try to unshare and reshare?
That would be great. I think it kicked a few of us out, and then when we get back in, it won't let us see anything.
Oh,
so
fine,
we can hear
sure.
you, but we just can't see.
Okay.
Okay, I will attempt
Sorry,
it.
Kate.
I don't.
I do have the slides open now, just in case. But that's looking
right.
And then if you just go back to the display settings and go back to.
Okay.
Yeah.
So if I just go on to 50, so can you all see that? This is learning in action. Can everyone see building block 2?
Yes.
No.
Yeah.
Brilliant.
Yes.
Okay. So shall I go on to the
Yeah, I
next
think we're
slide?
finished with that one. Yeah.
Perfect. So I'm just going to speak for a few minutes about a new service that we have designed, Birth Companions have designed. And the reason why this work started was because through our support for women and the evidence, we identified that there was a need for a new service which was specific for women who were at risk of separation. And we gained funding to carry out a co-design process. So we have co-designed it. So we now have a service that we are currently seeking funding for to run, fingers crossed, a 3-year pilot. And so what we did was first of all, I contacted members of our lived experience team and set up a kind of group. So 5 women with lived experience to help support and work with us on this co-design. And we made contact with over 40 local stakeholders in Hackney. So other organisations, so like safeguarders, social workers, midwives, bump buddies, PAWS, Solace, so statutory services, but also other organisations, and the advocacy project, lots of different people, and said, look, we think that we might need a new service for these women, but we don't know what it looks like. So what we want to do is come together, talk about it, find out what is available for these women, where the gaps are, and what it is that we could do to support these women. So we all came together. It was amazing. We had 6 kind of sort of focus group type meetings attended by 28 people. I had 14 one-to-one interviews for people that weren't able to attend that. And what we were able to do was really get an idea of what's going on in Hackney. And this is what we found out. So this is a bit of a whistle-stop tour, but what we found out is there's a need for continuity of care, that services were falling away too soon after birth. As Tamsin was saying, the health visitor doesn't visit because there's no baby. Women who are receiving specialist perinatal mental health in pregnancy then aren't able to continue with that when baby is removed, so they go back to the waiting list for generic generic adult mental health provision. So there was a specific support needed for women facing drug and alcohol addiction, and there was also a specific support for women who don't meet the learning disability threshold. So they weren't, the threshold is quite high, so there were a lot of women that didn't quite meet that threshold, but really needed support to navigate the complexities of children's social care. So there was a need for an independent advocate, someone who is not part of statutory services, to support a woman to navigate through pregnancy and beyond what happens with children's social care when the baby is sadly removed at birth. So, and there was also a lack of support for first-time mothers, and there was a lack of court recommended services, and also the waiting list for therapeutic support were quite long. So we were thinking, okay, so this is why we need a new service. How would it work? So we would recruit a member of staff who would join in our staff teams, and we have different teams for kind of the support that we're offering, but obviously we have birth support and we have antenatal classes, but we would have a new member of staff who would have a caseload of these women. They would offer emotional and informational support and advocacy. They would help navigate children's social care, so it would start as early as possible. So we would get referrals from midwives, from specialist midwives, from people like Tamsin, from social workers, and we would catch women as early as possible in that process and support them right the way through the pregnancy and then beyond. So 9 to 12 months post birth. So it's a really long kind of support intervention, and then the women would access other birth companion services, and we could signpost her to other local organisations that we met through the co-design, so that we were ensuring wraparound holistic care. So that's our vision. We hope that the kind of work with Ocean to develop the new mental health pathway, we would then, the person who was in this role would then be able to support women to engage with the services. So what we're trying to do is build something where we're able to connect in and give the women what they need, which is that wraparound care. And then just one more slide from me, the building block 3. So I wanted to just talk very briefly about giving women options. So thinking about, if you are developing a service in your area, is it going to be co-produced? Is there going to be peer support? Thinking about a walkthrough of that service, so thinking about it through their eyes. So how will they know it exists? Where is it? Will they run into mothers and babies there? So is that going to be the location going to be a trigger? Is there flexibility? Are there different options for the women to engage? So these were all the questions that we basically went through with Ocean, with women with lived experience, thinking about what kind of service that women need and when they need that service. And that is definitely a work in progress right now with Ocean. And we're hoping to kind of continue that. But really thinking about it, if you're thinking about in your area, thinking about the situation the women are in, how disempowered they are, how much guilt and shame they feel, and how can you develop a service to support women in this situation? What can you do to support them, and what might that service look like? Now, Tamsin, I'm due to hand over to you, but we do have some potential polls on this page. So I don't know if we want to do any of those now or if we want to put them in the chat. Are you there, Tamsin?
I have the poll set up if you want me to run it.
Oh, that would be brilliant. Thank you.
Yeah.
And then hopefully I'm going to pass over to Tamsin to run through the last few slides. But really the polls are thinking about, we asked you earlier what support is in your area. So now we're thinking about, okay, what words do you use to describe separation at birth? What What words do families use? Does your service have co-production? Do you have a service that you've co-produced? Are you thinking about co-producing a service? We'd be really interested to hear from you on these issues. So Celeste is going to put something up. I can't see it, but I'm going to leave that up, and then we've got the last few slides which Tamsin's due to do. Are you still on the call, Tamsin? Do you know if we've lost Tamsin, Celeste?
I'm just having a look now.
Because I can't see. I can just see the presentation on my screen, and I can't see.
Yeah, she's not in the meeting currently.
Okay, hang on, just bear with me 1 second. Can you let her back in? She said she's in the waiting area.
Okay, 1 second.
If we're able to do that. Now, whilst we're trying to get Tamsin back in for the last couple of slides, then if you're able to fill in the polls, I'm aware that we're not going to have masses of time, but what we are going to do is we're going to collect everything from the polls and everything that you're able to put in the chat. If you have any particular links that you want or questions that you have, if you put them in the chat, then what we'll do is we'll be able to see that, and we'll be able to connect with you and pass on any information that that you might need. And we'll also be able to kind of look and see what's happening in the different areas, and hopefully share that information. So I'm just waiting for Tamsin to come back in. We've literally got the last 3 slides. Yep, she's in the lobby, so hopefully she'll come back in and she'll be able to do the last couple of slides to finish off. Sorry about the IT issues that we have experienced during this. I hope that you've been able to engage with the presentation and be able to kind of get an idea of the way that Tamsin and I are working together, a statutory service and an organisation that's not statutory, to kind of work together to understand the needs of these women and be able to provide support for these women.
Kate, I'm back.
Aha! So Tamsin,
So sorry. Yeah.
That's okay. What we've done is I have done building block. I've done the last building block, and we've done a poll, and we've done some stuff in the chat. So what I'd like to do is pass over to you for the last 4 or last 3 slides. So we've got future vision on the screen for the next slide.
Yeah. So this is locally where I'm hoping at some point in the vaguely near future we're going to be. So the kind of the pathway, the kind of perinatal progress through the pregnancy and afterwards is along the middle there, and along the top I've got the MMHS, the perinatal mental health team support, and that's obviously continuing until, you know, further into the future, into the end of the perinatal period and beyond. Then obviously the specialist midwives are really key for supporting your women in a really meaningful way. And then the perinatal navigator service that we've been co-designing with Kate is what I hope will then be an additional part of this pathway, which actually does that work that women told us and repeatedly tell us is lacking at the moment, around having somebody who's there just for them, that works with them, is known to them, and is able to engage them in the postnatal period and support them to engage with things like the MMHS, and then transition them into another recurring care service if that's appropriate. Should we go on to the next one, Kate? So locally at Ocean, so I was seconded to be one of the project managers for maternity when we were developing Ocean. I'm not the midwife who's linked to it now, but there's lots of bits of work that we've thought about providing for this group. One of them is around support in a group setting, hopefully, for managing anxiety and stress in the antenatal period. So recognizing the anxiety and the worry that being pregnant again when a baby has been removed from your care, or an older child has been removed from your care, and thinking about helping people develop some of the skills they need in order to work successfully with social services, with other services, and kind of understand what those expectations are. Then we've been talking about an initial assessment, and I think if there's anyone from the Lotus team in Norfolk, I think this is something that they're doing really well at the moment already, is thinking about once in the postnatal period, doing an assessment, seeing whether somebody is ready or not for group work, thinking about if there's a waiting times, which there are, I understand, probably everywhere for the MMHSs. What support can we offer during that waiting time? Thinking about pre-engagement work, and I think again this is where the navigator service that we're hoping to set up is really going to come into play. Previously doing other projects where we are working with women with drug and alcohol issues in pregnancy, and we've kind of provided a weekly group. Some of the really important work was actually assertive outreach, going to women with a taxi to help them get to the group, bringing them in gradually and slowly. So maybe they come to the children's centre to see what it looks like, but they don't come into the group. Maybe they come and have a midwifery appointment there, but they don't come into the group. And you kind of build up to bringing someone into that setting in a way that they need, really. So I think that's probably something that is really important to think about here. The team are also thinking about running a courage group program, which is a narrative therapy, which is obviously I'm not an expert in this, and probably there's people in the room who are, but thinking about people in a chronological way to think about their experiences, their history, what they've gone through, and create a coherent narrative and understand where they are now in the context of where they've come from. And then the other bits we're thinking about are a post-separation support group, so peer support group from other mums. And what we'd like to explore is about co-facilitation with different members of the multi-agency, multidisciplinary teams within the